Good afternoon, all. Uh, I will be presenting mainly on rehabilitation of dentition in our patients in second stage, and I will be covering it through the cases I have done in past 15 years. So the aim of my topic would be to rehabilitate the patients in their pre-surgery stage in terms of function and aesthetics. So what we intend while we receive a patient for replacement of teeth, we need these common things like keratinized mucosa, sulcuses, fixed alveolar mucosa, good height for placement of implants. But something like this would be ideal scenario I would like to have. But what we usually get is these things: restricted mouth openings, severe fibrosis, no sulcuses, flap sitting, mobile mucosa. We also have similar explanation while we see these patients that these kind of things are there. In radiographically also see there is less bone height available. Sometimes there is no mandible or maxilla, so there is deviation, lot of deviation. Marginal mandibulectomy is done, so height of the bone is less, nerve is interfering. Last but not the least, the cost factor. So after going through all the cancer surgeries and radiation and chemo, patients are hardly left with any money. Funny part is that the patients who doesn't have mouth opening and favorable factors have a lot of money, and the patients who have good mouth opening, everything favorable, don't have any money. So practically, the rehabilitation, implant-based rehabilitation is usually as expensive as full cancer surgery. If I talk about one jaw reconstruction, there are multiple types of rehabilitation. One is removable, another is overdenture supported by implants or teeth, and third is implant supported fixed prosthesis. My main focus would be on fixed prosthesis because I feel that like we like fixed teeth, I think these patients also deserve to have fixed teeth, and removable teeth usually cause irritation and those are not very comfortable. So I will start. So before going for implant placement, some patients require vestibuloplasty, or we call vestibular deepening or debulking of the flaps, which I do usually two ways, sometimes before the implant placement or sometimes simultaneous. Like in this case, uh, the flap is sutured in the sulcus. It is laterally pushed. Then the implants are placed with 3D printed implant guides, and then the bone is left raw. I opt this in cases where radiation is not given. If the radiation is given, then I would keep a layer of periosteum over the bone to prevent ORN. So this is how it is done: simultaneous placement. This is another case where the periosteum is kept intact and only the radial forearm is taken laterally and a vestibular deepening is done. And then on top of it, we fix this kind of acrylic plates to hold the vestibule and maintain the vestibule. We'll start with case discussions. This is a 50-year-old patient with squamous cell carcinoma of lip, sulcuses, both floor of the mouth, marginal mandibulectomy was done, and you can see the flap. This patient didn't receive any RT. So this is how this patient was done in, I guess, 2016, so around 9 years back. So that time I used to make these kind of stents. This is just nothing else but just refills of the ball pen to just guide that where my implant angle should be. And this is how debulking was done: exposure and then placement of implants. So this is the marginal mandibulectomy area. These are the implants placed. And after taking measurements after osseointegration time of say around 3 months, which goes to lab, and lab makes this titanium bar which splints all the implants, and then it is wrapped with artificial gingiva and artificial teeth, and which merges these extensions go into the implants inside the mouth. So this is how it looks inside the mouth. This is removable by us, not by the patient. and this is how it looks on the OPG. This is 8 years follow-up, the longest follow-up I have. You can see all the skin has gone, hairs have gone, and mucosa is totally mucosalized with good attached keratinized tissue. So this is how it went from here to here to here. Next case is of 77-year-old patient, twice operated and radiated. If you see in this patient, some plate was put, and because of not using recon plate or doing pre-plating, the condyle is out of glenoid fossa and there was no alignment of the lower jaw. It is tilted lingually and only half of the mandible is there. And similarly, we planned the implant positions, placed the implants, and this is the similar prosthesis. You can see the implants are placed here, but the teeth are here, way away, to match the upper jaw. So this is how it looked after. So 2016, 2019 patient was here. Another case, very restricted mouth opening, segmental mandibulectomy was done, fibula was placed, but there was hardly any space on right side where fibula was there to put molar teeth. So we decided to give implants only in the anterior teeth. That was also not possible. So we decided to extract all the upper teeth. Patient agreed to that. So in the first stage, we came to know that the plate was fractured. The partial fractured plate was removed and implants were placed. Upper jaw, this is the radiologic guide to position where the implants would be, and implants were placed and then rehabilitated, say, after 6 months, like this. Another case, this is a non-malignant case. This is a case of ameloblastoma, recurrent ameloblastoma. Patient got operated for curettage in 2010, then 2016, then 2022 again. And I think this time we operated with resection and fibula grafting. Very less skin was required. So as it was not oncologic resection, so very less skin was required. This is after the healing, say after 6 months, good union. Again, the height is very less. If you can appreciate, this is the soft tissue shadow. This much vertical height of soft tissue was there. This is the planning which I do nowadays, virtual surgical planning, so that I can place my implants virtually between the screw, so I don't need to remove the screw. This whole procedure is done under local anesthesia in a dental chair. And after this planning, a 3D surgical guide for implant placement is made like this. It is 3D printed. After putting this guide on the bone, the implant osteotomies are made. You can appreciate the plate over here. And this is how immediate post-op it was. Debulking was also done on the same sitting, and sometimes it requires 2 or 3 times debulking. This is the measurement steps, and this is the final prosthesis. This is a very recent case. We keep on trying on changing the materials each and every time to see that post-op, if these patients require MRIs or CT scan, these heavy metal prostheses do not impede the radiologist evaluation. So this is the place. If the previous case is, you see there was a titanium bar, this is a material called PEEK, which is less radio opaque, and it has a printed acrylic teeth over it which are hardly visible in this. The teeth are here, but they are not visible on the X-ray. So this is what latest with what we are doing right now. Another case of ameloblastoma flown from Bahrain, and we did fibula resection and fibula in 2019. Then we bone union is still not happened, so we waited for around, I think, 2 years till the union happens, and then again virtual surgical planning, 3D printed guide, and these are the implants placed in the fibula, corrected with multi-units, and this is what it was immediate post-operatively. And these are the measurement steps: the vertical bite registration, the shade matching. This is in the lab, one piece. This is a titanium framework and individual zirconia crowns, and this is the pink shading given later on. So this is inside patient's mouth. and individual teeth will be, zirconia teeth will be cemented on top of it, and this is it like. So from here to here it is fibula, and these are the artificial teeth. So this is how it looks, the X-ray. So from here till here. Another case, non-radiated left buccal mucosa, pure left buccal mucosa, radial forearm flap sutured over the alveolar mucosa. So we try to use skin is a good keratinized tissue. Only thing it is not fixed. So this is the surgical guide. We just separate the skin, place the implants, and that's it. The rest, everything is taken care of by itself. So these are the fixed teeth over the implants. So this is the outcome. This is another case. Patient operated in 23 with marginal mandibulectomy. So the nerve was sitting on top of it. So we had to tilt the implant to go beyond it. This is the planning software, which I can see that whether I am going exactly bang in the center or not. And this is the virtual surgical planning again. If you see, I can plan my implants virtually, then the 3D printed guide and my drills go exactly in the same direction where I had planned. So this is immediate post-operatively. This is the mental foramen, and the implant is lingual to that. This is the temporary prosthesis. This is the final prosthesis. Another case, this patient was radiated, which he had a disease in floor of the mouth, buccal mucosa, lingual mucosa, and this patient also has a marginal mandibulectomy done. So the nerve was sitting on top of it. In this case, to give molar to the tooth, I had to lateralize the nerve. So using piezo, you lateralize the nerve. The nerve is lateralized, and the tilted implant was placed here. So this is how the implant was placed, and the nerve was lateralized, and then the prosthesis was given. Same virtual surgical planning, 3D printed guide, and then placement of implants. Another case, she is a hero lady, fighter. She got operated so many times since 2010. First, she was diagnosed with CA tongue. Totally primary closure was done, no flap was used. Second time in 2019, she developed with CA tip of the tongue, and she got CA breast also. We operated her again and gave total tongue was replaced with total glossectomy, replaced with radial forearm flap, no sulcus is left, but she was hell bent that I want teeth, I want to chew properly. So we explained her all pros and cons, and then when we went ahead with simultaneous placement of implants and debulking of the flap and release of the tongue as well as the lip. So these are the implants placed. Then so from 22 we gave her like this. Then later on she operated for breast malignancy. Then she developed bronze in upper left maxilla and right mandible, and now she has liver mets also, and but still she is with teeth. Another case of marginal mandibulectomy where no sulcus is there, debulking, same protocol, 3D virtual planning of implants and multi-units, and 3D printed guides, placement of implants, and this is the planning and this is the execution. And this is where it was. Later on, this patient developed a second malignancy, recurrence in the right RMT. So we had to knock down from here and remove this implant, and this prosthesis was cut from here, and only these many teeth are given right now. Planning to, after the union is there, planning to place implants here also. Another case of marginal mandibulectomy, central arch case, similar planning. And this patient, we lost this implant, so planning to put two new more implants here. The prosthesis was cut and given on only 3 implants right now. It is like this right now. This is the radial forearm flap which was used, which was debulked and pushed lingually, and the lip was also separated. This is a case of CA left hemimandible, segmental mandibulectomy and fibula was done in 2019. No adjuvant was given to this patient. She had good mouth opening. Only thing, flap was too bulky, the upper teeth were touching. And this is the same case. This is what the final outcome is from here to here. This case I just wanted to show. This is also a marginal mandibulectomy case just to show the prosthesis. This is also a peak prosthesis with zirconia crown, so less radio opaque material. This is a case of mucormycosis, not malignancy, but quad zygoma was planned and patient was rehabilitated with fixed teeth. He had bilateral maxillectomy done, and this is the prosthesis. So these kind of fixed prosthesis can be given. Sometimes if patient has some issues regarding finances or any other clinical issues, we can give removable prosthesis also. This patient is having segmental mandibulectomy and maxillectomy. So this is the removable prosthesis on the support of only 2 teeth. This is the obturator, immediate surgical obturator. If there is no support, we can fix them with screws also, keep it for 3 weeks and then you can make a new obturator. These are the obturators which are final obturators after 3 to 6 months. With teeth also can be given. These are removable ones. These are also removable one overdentures. These are maxillary overdenture, bar and clip, mandibular overdenture, ball and socket. Thank you very much. And questions, please. Thank you, ma'am.